Right. So, a very good evening, everyone. I welcome you all to this particular session of emergencies in the neurology. So, in the previous sessions, we have discussed cardiac emergency, endocrine emergency, and as well as respiratory emergencies. So, in this particular session, I'll be discussing the emergencies within the neurology. Now, it is just a rush through. It is not a detailed explanation of the individual neurology emergency. So, this will be a rush through which will be helpful for your upcoming NEET PG exam and as well as the FMG exam. So, the first and foremost, the very important neurology emergency will be the seizures. So, what makes threatening for a patient or the patient attenders is the development of seizures. And not all the forms of seizures they present to the casualty or the emergency department. The forms of seizures which present to the emergency department in the form of an emergency is one is status epilepticus, myoclonic jerks, atonic seizures which are also called drop attacks, and then eclampsia that is in pregnancy. Now, if you take the quick discussion on the status epilepticus. So, status epilepticus, what is that? The individual will be having continuous episodes of seizures, and in this continuous episodes of seizures, in between the episodes, the individual will be in a state of loss of consciousness, and that is what is your status epilepticus. And all these particular episodes, they continue up to 30 minutes, right? All these particular episodes they may continue for 15 to 30 minutes. Or the other important definition of the status epilepticus is one episode, if it is lasting for nearly around 5 minutes, then that is also called as the status epilepticus. Now, what is the drug of choice for the status epilepticus? Drug of choice for the status epilepticus is the lorazepam. And how much of lorazepam you have to give? 0.1 to 0.15 milligrams per kg. So you have to give one dose, and if the epilepsies are continuing, you can repeat the second dose after 5 minutes. So you can give 2 doses of lorazepam. And even with lorazepam, if the episodes are not subsiding, then you can give 2 doses of the phenytoin. And what will be the dosage of the phenytoin? You need to give 20 milligrams per kg of phenytoin. And if the seizures are still continuing, you can give 10 milligrams per kg of phenytoin. So 2 doses of phenytoin you have to give. And if the episodes are still continuing, the next important drug that you can give is the valproic acid. And how much is this valproic acid? You will give 25 milligrams per kg intravenously you have to give. And in spite of giving valproic acid, if the episodes are still continuing, then you need to give phenobarbital, right? And even this phenobarbital, you have to give 2 doses. The first dose should be 20 milligrams per kg IV. And if the seizures are still continuing, then you can give 10 milligrams per kg IV of the phenobarbital. Okay, and in spite of giving phenobarbital, if the seizures are still continuing, then you need to knock out the patient by giving anesthesia. So you either give propofol or midazolam and then you knock out the patient. So that is what is the treatment in case of the status epilepticus. And why is that you are very much worried about in case of the status epilepticus? See, these individuals with status epilepticus, they can die if you don't treat. And what do you think would be the cause of death in these patients? That could be because of the aspiration pneumonitis that can cause death. The death could be because of the hyperthermia, and the death could be because of metabolic acidosis. Okay, so these are the causes of death in a case of status epilepticus, and that is the reason why on an emergency basis you need to treat these patients. So that is about the status epilepticus. And the next important form of epilepsy which can present to the emergency department is the myoclonic jerks. So these myoclonic jerks, they are most commonly seen in the adolescent age group. And this particular myoclonic jerks, which part of the body you can have these myoclonic jerks is mainly within the extremities. Bilaterally you can have in the upper limbs. And this particular myoclonic jerks you can see even over the trunk. And what will be the precipitating factors for the development of this myoclonic jerks? If the adolescent individual, if they had a decreased sleep, right, or the alcohol consumption, that could precipitate the development of this myoclonic jerks. So mainly they are seen in adolescents. So we can also call this as the juvenile myoclonic epilepsy. Then followed by that, you need to know how to diagnose this juvenile myoclonic epilepsy. That is by EEG. So when you do an EEG, EEG will show you that there is 4 to 6 hertz irregular polyspike activity. That is what you will see in case of the juvenile myoclonic epilepsy. And what will be the drug of choice in case of your juvenile myoclonic epilepsy? The drug of choice will be valproic acid. So that is about your myoclonic jerks. Important points about the myoclonic jerks. Then coming to the atonic seizures. See, these atonic seizures, they are nothing but the drop attacks, right? So in these individuals, suddenly there can be loss of tone within the muscles of the body, and the individual can have a sudden drop. Okay, and that is loss of posture, and that is what is called the drop attacks. And you need to know these atonic seizures, they are commonly seen in children. And what are the precipitating factors for these atonic seizures? See, there are certain triggering factors like hyperventilation. Okay, hyperventilation. And when the individual sees flickering lights, right, these are the triggering factors for the development of the atonic seizures. And one episode of atonic seizure, it can last for nearly around 15 seconds. And these atonic seizures, they often start in the childhood and they can get continued even into the adulthood. Okay, and what will be the drug of choice in case of atonic seizures? Drug of choice in case of atonic seizures is valproic acid. And if the individual does not respond to the medical management, then you need to do a surgical approach. And what is that particular surgical approach? You need to do a selective posterior calosotomy. The surgical approach will be posterior calosotomy. That will be the treatment for the atonic seizures. And then followed by that, the other important form of seizure that can present to the emergency department is the eclampsia. So eclampsia that we see in pregnancy, so the treatment will be magnesium sulfate. And wherever you are giving this magnesium sulfate, what is that you need to monitor? You need to monitor the knee jerk. And once the knee jerk disappears, it tells you that you are giving toxic doses of magnesium sulfate, where you need to stop giving magnesium sulfate. Okay. So these are the forms of epilepsies which can present to the emergency department in the emergency scenarios. You have other forms of epilepsies like absence seizures. They don't present to the emergency department. Okay. Right, so they can present to the OPD, and depending upon the history, we will be able to make out the child is suffering with the absence seizures. And when you do an EEG in case of absence seizures, you will have 3 heads, spike and wave pattern. And the drug of choice, if the child is less than 4 years, you need to give ethosuximide, and if it is more than 4 years, you need to give valproic acid in case of absence seizures. And the other thing is the focal epilepsy. Even focal epilepsies, they can present to the emergency department, and in case of focal epilepsy, the drug of choice will be carbamazepine that you have to give. Now, after having discussed about the epilepsies which are presenting to the emergency department, let me take up the next important discussion of the neurological emergency, that is the cerebral sequelae after the head injury. This is another very important neurology emergency. And what are the various sequelae they can have? Right, there can be concussion, there can be like contusion, epidural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, intracerebral hemorrhage, and even there can be diffuse axonal injury as well. Now, let me just give you briefly what will be the clinical presentation of these cerebral sequelae. You take in case of concussion, there will be a transient trauma-induced alteration in the mental status. Okay, and there may or may not be loss of consciousness in case of the concussion. Right, and other features like headache, nausea, disorientation, irritability, clumsiness, visual disturbances, they are also present in case of concussion. And what is the pathology in case of concussion? That is due to mild diffuse axonal injury. That is what is responsible for your concussion. And even cerebral contusion may also occur in case of concussion. Then next, followed by that, the another important cerebral sequelae of the head injury is cerebral contusion. So here the loss of consciousness will definitely be there, and it will be longer than the concussion. And not only loss of consciousness, even the focal neurological deficit will be present in these patients with the cerebral contusion or the laceration. Okay, and these patients with cerebral contusion, if it is very severe, they may even die. Then what will be the pathology in case of this cerebral contusion? The pathology, it is mainly your coup and as well as the counter coup injury. So coup injury is like bruising on the side of impact. Wherever is the side of impact is there, that is coup injury. And contralaterally, that will be the counter coup injury. And in case of this cerebral contusion, these individuals, they can have the pathology in the form of, one is your coup and sound counter coup injury. They may have subarachnoid bleeding, right? They may have subarachnoid bleeding. And what would be the cause of death in these patients? In severe cases, there will be herniation, right? In severe cases, there can be herniation, and that could be the cause of death in case of the cerebral contusion. And another important cerebral sequelae of your head injury is acute epidural hemorrhage. And in case of acute epidural hemorrhage, what is very, very important is they will have headache, they will also have confusion, they can also have seizures, they also have focal neurological deficit. It will occur several hours after the injury. But very, very important point in this is the presence of the lucid interval, right? The presence of the lucid interval, during which the individual will be completely symptom free. Again, after that, there will be development of these symptoms. And these patients with acute epidural hemorrhage, they can also develop coma, respiratory depression, and even death. And why does this acute epidural hemorrhage occurs? That is mainly due to tearing of meningeal artery. Okay, that is mainly due to tear within the meningeal artery. There can be development of this acute epidural hemorrhage. And next is the subdural hemorrhage. So if you take this subdural hemorrhage, what will be the symptoms? The symptoms, they are similar to that of your epidural hemorrhage, but interval before the onset of symptoms will be longer. Okay, so the interval before the onset of symptoms will be longer. And these patients with subdural hemorrhage, they require neurosurgical consultation for consideration of evacuation of subdural hemorrhage. Okay, and what would be the pathology? It is due to rupture of the bridging veins, right? It is due to rupture of the bridging veins. So you have the bridging veins connecting the cerebral parenchyma and superior sagittal sinus, and due to rupture of this bridging veins, the individual will develop acute subdural hemorrhage, and then followed by that cerebral hemorrhage. Cerebral hemorrhage, this will generally develop immediately after the injury. And one of the very important risk factor you need to know regarding the cerebral hemorrhage is the hypertensive hemorrhage. Now, what would be the most common site for your hypertensive hemorrhage? That will be in the basal ganglia, that is at the putamen, right? That is at the putamen. And the pathology is that you will see the presence of hematoma on the CT scan. The next, another important cerebral sequelae is diffuse axonal injury. In case of diffuse axonal injury, the individual will be in a state of persistent loss of consciousness, right? Persistent loss of consciousness, and the individual will go into a state of coma. He will be in a persistent vegetative state, right? He will be in a persistent vegetative state, and that is resulting from a severe rotational shearing forces or deceleration. And like whenever you do imaging, like what is that you will observe? You will observe a tiny scattered white matter hemorrhages, right? A tiny scattered white matter hemorrhages that you will see within the CT scan. And whenever you do the histology, what is that you will observe within the histology? Within the histology, you will notice that there are torn axons, right? There are torn axons. So that is about your diffuse axonal injury. Then the next important form of the cerebral sequelae that we need to discuss, okay, right? The next is the subarachnoid hemorrhage, which I'll discuss that. Now you need to know the source of bleeding. Abhishek, role of levetiracetam in emergency. So in emergency situation, levetiracetam as such, there is no role. Lorazepam is the drug of choice in emergency. Okay, right. Then source of bleeding in the intracranial hemorrhages. So like epidural hemorrhage. This most commonly caused by rupture of the middle meningeal artery, right, which is a branch of maxillary artery. You take subdural hemorrhage. Where is the source of bleeding? That is due to rupture of superior cerebral veins, right? That is due to rupture of the superior cerebral veins. Okay, they are nothing but the bridging veins that connect the cerebral cortex to the superior sagittal sinus. Then coming to the subarachnoid hemorrhage. Subarachnoid hemorrhage, the source of bleeding is rupture of the saccular aneurysm. Okay, rupture of saccular aneurysm. Then finally, the intracerebral hemorrhage. So for the development of intracerebral hemorrhage, what is the most common vessel which is being ruptured? It is lenticulostriate branch, right? Lenticulostriate branch of middle cerebral artery. That particular vessel rupture is responsible for the intracerebral hemorrhage. Okay, and whenever there is a head injury, how will you assess the severity of the head injury? The assessment of the severity of the head injury is by the Glasgow coma scale, right? And this particular grades of traumatic brain injury are traditionally defined by Glasgow coma scale, which is being measured 30 minutes after the injury, right? And in this GCS, what you need to calculate is you need to calculate the GCS P score, right? You need to calculate the GCS P score. Now what will be there in the GCS P score? Everyone is aware of EVM, that is eye opening, verbal response, and as well as the motor response. But what do you understand by the word P? The word P stands for the pupillary response. The word P is your pupillary response. For suppose if both the pupils are non-reactive, then you need to give a score of 2. And if only one pupil is non-reactive, you need to give a score of 1. And if both the pupils are reactive, then you need to give a score of 0. So this is what is called as GCS P scoring system. And depending upon the score, we can indicate the severity of traumatic brain injury. So when will you call mild? Mild traumatic brain injury, the GCS score is around 13 to 15. Moderate, it is 9 to 12. Severe, the score will be less than 8. And in these patients with the traumatic brain injury, what are all the other things that you need to examine? You need to examine for the signs of the scalp laceration, facial injury, skull fracture, and neck injury. So skull fracture, mainly the basal skull fracture, there are two important signs. What are those two important signs? One is your raccoon sign, right? So the clinical signs of basilar skull fracture, it includes bruising about the orbit. And that bruising about the orbit, that is what is called as the raccoon sign, right? Bruising about the orbit is called raccoon sign. And it is a clinical sign of the basilar skull fracture. And the another important sign is the battle sign, right? The another important sign is the battle sign. What is this? It is nothing but a retroauricular ecchymosis, and this is associated with the fracture of the auditory canal and lower areas of the skull, right? This is associated with the fracture of auditory canal and lower areas of the skull, and that is what is called as the basilar sign, sorry, battle sign. So in case of traumatic brain injury, all these you have to look for. Then depending upon the cerebral sequelae, how will you diagnose? Like you take concussion. See, concussion is diagnosed by history of loss of consciousness. And will there be any particular sign on the CT scan? Nothing. CT scan of the head will be absolutely normal. Then you take the epidural hematoma. In case of epidural hematoma, you have a lens shaped hyperdense lesion will be there. I will show you that CT scan. And in case of the subdural hemorrhage, you will have a crescent shaped, right? You will have the crescent shaped hyperdense lesion will be there. Whereas in subarachnoid hemorrhage, you will have the presence of the blood within the sylvian fissure. Right, you will have the presence of the blood within the sylvian fissure. That is what you will see in case of the subarachnoid hemorrhage. Then in case of contusion, you have the presence of the petechial hemorrhages. Right, you will have the presence of the petechial hemorrhages, and there can be a depressed skull fracture. That is what you will have in case of cerebral contusion. Then coming to the diffuse axonal injury. In case of diffuse axonal injury, you have extensive gray white matter junction regions which are abnormally being present. So what is that you will see in the CT scan of diffuse axonal injury is you have both. You have the presence of the petechial hemorrhages, and along with the petechial hemorrhages, you also have the presence of a hypodense foci. Right, you have the presence of the hypodense foci, and these patients with diffuse axonal injury, they carry extremely worst prognosis. Right now, so this is the CT scan of the epidural hematoma, right, which you have a lens shaped hyperdense lesion, then followed by that subdural hematoma, which is crescent shaped, then subarachnoid hemorrhage, where you have the presence of the blood within the sylvian fissure, then the cerebral contusion, where you have the presence of the petechial hemorrhages, then diffuse axonal injury, you have both petechial hemorrhages and as well as the hypodense foci. And this particular diffuse axonal injury, in which particular lobe they are most concentrated is within the frontal lobe. Right, then next important thing is the treatment in case of the head injury. The treatment is, first and foremost, very important is how will you lower the intracranial pressure. See, if you want to have an acute response and if the individual is conscious, you can ask the individual for doing hyperventilation. Right, hyperventilation, and you have to ensure that the partial pressure of the carbon dioxide is around 30 to 35 millimeters of mercury. So whenever you do a hyperventilation which causes carbon dioxide washout, that will cause vasoconstriction of the cerebral vessels, and then a drop in the intracranial pressure can be achieved. And if at all, if you want to give the drugs to be given for reducing the intracranial pressure is the osmotic diuretics you need to give, and that is mannitol. Right, that is mannitol. And the other thing is you need to elevate the head of the bed. Okay, you need to elevate the head of the bed. And by 30 degrees. Right, you need to elevate the head of the bed by 30 degrees, and you need to maintain the systolic blood pressure of nearly around 110 to 160 millimeters of mercury. Right, a slight degree of hypertension assures that cerebral perfusion pressure is adequate. And remember, in case of head trauma, steroids are not effective at all. Then finally, what is the indication for surgical treatment in case of these patients with subdural hematoma or in case of epidural hematoma? So what has been given here is the subdural hematoma. So if the thickness of the hematoma, right, if the thickness of the hematoma is around 10 mm or more, then it's an indication for surgical intervention. Right, and if there is a midline shift, right, if there is a midline shift of more than or equal to 5 mm, that is an indication for surgical treatment. And if there is decline in the GCS score of 2 or more from the injury to hospital admission, So if there is decline in the GCS score of more than or equal to 2 from injury to the hospital admission. And the other indication for surgical treatment is if the pupils, right, if the pupils are fixed and dilated, either one or both the pupils, if they are fixed and dilated, that is another indication for surgical treatment. So this is about your traumatic brain injury and what are all the various cerebral sequelae. And another important emergency that can be presenting to the casualty related to the neurological disorders will be the headache. Not all the types of headache will present to the casualty. One is cluster headache, the other one is SUNCT, right? What is this particular SUNCT? That is short lasting unilateral neuralgiform headache with conjunctival injection and lacrimation. And the other form of headache is paroxysmal hemicrania, which can present to the casualty. And next is subarachnoid hemorrhage, where you have thunderclap type of headache. Now let me just tell you some important points related to this particular headache. So first you take this cluster headache. So what will be the character of the headache? It will be stabbing type of headache, right? And in case of SUNCT, you will have a burning or the stabbing type of headache that you will see in SUNCT. Whereas in paroxysmal hemicrania, you will have stabbing or throbbing type of headache. But when the patient has stabbing type of headache, then he can present to the casualty. And what will be the site of this headache? The cluster headache, it will be in the periorbital area and occasionally over the temple. And SUNCT, it is mainly periorbital area. Whereas paroxysmal hemicrania, it is also similar to that of your cluster headache, that is over the orbit and the temporal region. And what will be the attack frequency? This cluster headache, there can be one attack to 8 attacks per day. Whereas SUNCT, there can be nearly 300 to 200 episodes per day. And how many are required for diagnosis? More than or equal to 20 episodes per day are required for the diagnosis. Whereas paroxysmal hemicrania, 1 to 40 episodes per day can be there, right? And what will be the duration of an individual attack? So this cluster headache, in one particular episode, it can be from 15 minutes, right? It can be from 15 minutes to 3 hours. Whereas SUNCT, it is present each particular episode, it will be there in seconds, that is 5 to 240 seconds, right? And paroxysmal hemicrania, one particular episode will be there for nearly around 2 to 30 minutes. And what about the autonomic features? Yes, autonomic features will be present in all the forms of headache. And what will be that autonomic features? Like conjunctival injection, lacrimation, that will be the autonomic features. And what will be the active treatment? So in these patients with the cluster headache, you need to give high flow oxygen, and drug of choice for very severe acute attack will be sumatriptan. Whereas in SUNCT, you need to give intravenous lidocaine. Whereas in paroxysmal hemicrania, there is no effective treatment as an active treatment. Mainly, we give this indomethacin, right? Indomethacin. Okay, then followed by that, you need to know the prophylactic treatment. Prophylactic treatment in case of the cluster headache, you can give verapamil as a long-term prophylactic treatment. Okay, whereas short-term prevention, you can give steroids, that is prednisolone. And for SUNCT, the prophylactic treatment will be lamotrigine, or you can give topiramate or gabapentin. And the prophylactic treatment for your paroxysmal hemicrania, it is the same, that is you need to give indomethacin. Then another important neurological condition which can present to the casualty in the form of an emergency is the meningitis, and as well as the meningoencephalitis. So in case of meningitis, you will have a high grade fever, and the individual will have very severe headache. And along with this severe headache, the worrying thing is they will be having the projectile vomiting, and they also have the photophobia. So these are the symptoms with which they present to the emergency department. And what is the difference in meningoencephalitis? In meningoencephalitis, along with the headache, the individual can also have the seizures. The individual can also have the altered sensorium. Okay, so that is what you will see in case of meningoencephalitis. But how will you diagnose this particular meningitis? The investigation of choice in case of meningitis will be the CSF analysis, that is the lumbar puncture. Now let me quickly recap the lumbar puncture of all the forms of meningitis. So first and foremost, you need to know the normal first. So how much is the normal CSF pressure? That is 50 to 180 millimeters of water. And normal color of the CSF will be absolutely clear. And the number of cells will be 0 to 5 cells per cubic millimeter. And mostly they are of lymphocytes. And what will be the glucose levels? That will be 2/3 of the blood glucose, right? 2/3 of the blood glucose. And what will be the protein content? The protein content will be around 15 to 45 milligrams percentage. That will be the proteins in the CSF. Then what about acute bacterial meningitis? And in all the forms of meningitis, the CSF pressure is elevated, right? The CSF pressure is elevated, except in your case of your Guillain-Barré syndrome. And how will be the color of the CSF in case of acute bacterial meningitis? It will be turbid. Whereas you take the number of cells in acute bacterial meningitis, it is mainly neutrophilic predominant, and the number of cells will be more than 1000 cells per cubic millimeter. And the sugar will be decreased because the bacteria will utilize the glucose. And against the bacteria, the immunoglobulins are being formed. Antibodies are being formed, and these antibodies are nothing but the proteins. So your proteins are elevated within the CSF. And what about tubercular meningitis? The color of the CSF, it will be straw colored, and the cells will be increased more than 100 cells per cubic millimeter, and most of them they are lymphocytes. And what about the CSF glucose? It will be reduced. Even tuberculous organism will utilize for its growth. And even against the tuberculous organism, the antibodies are being formed, which are nothing but the proteins. So that is the reason why the CSF proteins are being elevated. And what about the viral meningitis? The CSF color will be clear in case of viral meningitis. And even the cells are elevated, but that will be more than 25 cells per cubic millimeter, and they are mainly lymphocytic predominant. And the sugars, they are more or less normal, and the proteins will be elevated. See, Guillain-Barré syndrome is nowhere related to your meningitis, but one important CSF picture in case of Guillain-Barré syndrome that you need to know is albuminocytological dissociation. Albumin levels will be very high compared to that of the number of cells. Cells will be normal, but albumin levels will be very high. And differential diagnosis for your albuminocytological dissociation is the Freund syndrome. That is in case of a spinal block. Then what about the fungal meningitis? So if you take the fungal meningitis, the CSF pressure is elevated, the CSF will be absolutely clear, and the cells will be elevated, that is 25 to 500 cells per cubic millimeter, and mostly they are of lymphocytic predominance. And even the fungi, they utilize the glucose, so the glucose will be reduced, and the proteins, either they are normal or increased in case of the fungal meningitis. And treatment is given accordingly. For acute bacterial meningitis, we give 2 grams of ceftriaxone empirically. Tubercular meningitis, we start with the anti-tubercular therapy. Viral meningitis, right, we give acyclovir. And your fungal meningitis, we give amphotericin B or flucytosine or even fluconazole. Okay, so that is about the treatment in case of the meningitis. And next important emergency within the neurology will be the stroke, right? The another important emergency will be the stroke. So what is the most common cause of stroke? The most common cause of the cerebrovascular accidents will be the embolic strokes. The embolism is the most common, right? Embolism is the most common, right? Then now you should know like the time of onset and as well as the progression. See, this hemorrhagic stroke, it occurs mainly during the activity, and the progression is over minutes and hours. And this thrombotic stroke, it can occur in a resting state also, that is in sleep. And on waking up or over hours, there can be progression. Whereas embolic stroke, it can occur at any time, right? It can occur at any time. Within seconds, right? Within seconds, there will be progression of this particular embolic stroke. And what about transient ischemic attacks? Transient ischemic attacks, they are present only in case of ischemic stroke, that is thrombotic and as well as the embolic stroke. And then next is the headache. The headache is more prominent in case of the hemorrhagic stroke than compared to that of the thrombotic and as well as the embolic stroke, right? So whereas in thrombotic and embolic stroke, they are mild and absent. And what about early resolution of the neurological deficit? The early resolution of the neurological deficit, it is possible in case of embolic stroke, but not in case of your hemorrhagic or thrombotic stroke. And what about meningeal irritation? Meningeal irritation may be present in case of hemorrhagic stroke, but not in case of thrombotic or embolic stroke. And what about this carotid bruit? Carotid bruit, it is present in case of thrombotic stroke, right? There will be the carotid artery atherosclerosis, because of which there can be carotid bruit. And in embolic stroke, possible chances of the carotid bruit. Then what about the valvular heart diseases? Valvular heart diseases and atrial fibrillation, it is very much significantly present in case of the embolic stroke. Now, how will you diagnose these particular strokes? That is mainly by your imaging, right? And that particular imaging is your CT scan. So in case of CT scan, if it is an ischemic stroke, you will have a hypodense lesion, right? Whereas in hemorrhagic stroke, you will have the hyperdense lesion. That is how you will diagnose this particular stroke. And the very important discussion within the stroke will be the brainstem stroke syndromes. And how will you diagnose these brainstem stroke syndromes? Please remember one important point: they will have crossed findings. So they will have ipsilateral facial manifestations, contralateral motor abnormality will be there. So whenever you are having these crossed findings, think of the brainstem stroke syndromes. And if you are thinking brainstem stroke, then where should be the site? Is it midbrain? Is it in the pons, or is it in the medulla? So how will you make out? That is depending upon the cranial nerve involvement. Like for example, you take the midbrain stroke syndromes. So the cranial nerve which is being affected is the third and as well as the fourth cranial nerve. For suppose, along with the contralateral hemiparesis, if the individual is having ptosis, then you just assume the site of lesion is within the midbrain. And for suppose, along with the contralateral hemiparesis, if the individual is having element facial palsy, then you suspect the site of lesion is within the pons. And along with the contralateral hemiparesis, for suppose, if there is lower motor neuron paralysis of the tongue, then you need to suspect the site of lesion is within the medulla. So third and fourth cranial nerve manifestations are there. Site of localization is midbrain. Fifth to eighth cranial nerve lesions are there. The site of localization is within the pons. Ninth to 12th cranial nerve lesions are there. Then the site of lesion is within the medulla oblongata. Now, first let me discuss this midbrain stroke syndromes. Right? Brainstem stroke syndromes is a very important area of questions in your entrance exams. So you take the midbrain stroke syndromes. What are all there? Weber's, Benedict's, North-Nagel's, Claude's and Perinoud's. See, if your luck is good enough, they will just ask you which among the following is not midbrain stroke syndrome. Right? One of the option will be like locked-in syndrome, which is a Pontine syndrome. So you can easily make out. So at least first of all, you need to know the names. Okay, and what is the vessel which is being affected for the development of your midbrain stroke syndrome? That is mainly the posterior cerebral artery. Now, if you see the individual structures, in case of Weber's, there will be third cranial nerve, ipsilateral, and there will be contralateral corticospinal tract and as well as the corticobulbar tract. And what about Benedict's? Benedict's, you have the involvement of the third cranial nerve. Along with that, there is corticospinal tract involvement, there is corticobulbar tract involvement, and there is also the involvement of the red nucleus in case of the Benedict's. So whenever there is involvement of the red nucleus, the individual will have contralateral intentional tremors. Then what about this North-Nagel's? See, North-Nagel's, it is due to injury to the superior cerebellar peduncle. And along with the superior cerebellar peduncle, there will be ipsilateral third nerve palsy. And because of this superior cerebellar peduncle involvement, there will be contralateral cerebellar ataxia, right? Contralateral cerebellar ataxia. Okay. Then what is your Claude syndrome? Claude's is very simple. If you combine Benedict's and as well as North-Nagel's, that will be your Claude syndrome, right? You combine Benedict's and North-Nagel's, that will be your Claude syndrome. That means what are all structures which are affected in your Claude's now? Third cranial nerve, corticospinal tract, corticobulbar tract, red nucleus, and as well as the superior cerebellar peduncle. And perinods is very simple, where there is involvement of the superior colliculus. And because of the involvement of superior colliculus, they will have bilateral vertical palsy, right? They will have bilateral vertical palsy. So that is about your midbrain stroke syndromes, and mainly due to the involvement of posterior cerebral artery. And the next important stroke syndrome is the Pontine syndrome, right? So what all Pontine syndromes we have? Ventral Pontine syndrome, bilateral ventral Pontine syndrome, which is nothing but locked-in syndrome, lower dorsal Pontine syndrome, which is called Foville syndrome, and then Raymond-Seston syndrome, which is upper dorsal Pontine syndrome. See, the names of the Pontine syndromes itself, they can ask you as a multiple choice question. Okay, right. Now, for the development of these Pontine syndromes, what are the vessels which are being affected? See, in for the development of lateral Pontine syndrome, the vessel which is being affected is the ICA, that is anterior inferior cerebellar artery. And for the development of medial Pontine syndromes, the vessel which is being affected is the branches of the basilar artery. Now, let me discuss about the individual Pontine syndromes. What are the structures which are being affected? So, you take the Millard-Gubler's. The structures which are being affected is the sixth nerve, ipsilateral seventh nerve, and there will be contralateral corticospinal tract. So whenever the sixth nerve is affected, abducens is gone. So lateral rectus is gone. And seventh nerve is affected, there will be ipsilateral element palsy of the face, right? And corticospinal tract is affected, there will be contralateral hemiplegia. And the most common cause of the Pontine infarction is your locked-in syndrome. See, in case of locked-in syndrome, the individual will have only vertical eye movement. All other movements are lost. These individuals, they will have quadriplegia. Why is that? That is because of bilateral damage to the corticospinal tract in the ventral pons. And these individuals, they are unable to speak. They are unable to speak. And they are incapable of the facial movements. Why is that? That is because of the involvement of corticobulbar tracts, right? And they have a limited horizontal eye movement, right? Horizontal eye movement is limited. And why is that? That is because of bilateral sixth nerve palsy. And they have only intact vertical eye movement. Why is that only vertical eye movement is intact? And even they can also have intact blinking. That is because the supranuclear oculomotor pathways, they are being spared. Because the supranuclear oculomotor pathways are spared, the bilateral vertical eye movement is intact. And they also have preserved consciousness. So why is that you think like consciousness is being preserved in these individuals? That is because reticular formation is not damaged. So that is the reason why the consciousness is being preserved. Then coming to your Foville syndrome. So in Foville syndrome, which is a lower dorsal Pontine syndrome, the nerves which are affected is 6th, 7th and corticospinal tract. And along with that, there is involvement of paramedian Pontine reticular formation, that is PPRF. Okay, so in these individuals, what will be the features? There will be ipsilateral horizontal gaze palsy, ipsilateral whole face being paralyzed, and then contralateral hemiplegia with sparing of contralateral face. Okay, so that is about your Foville syndrome. And the next is the Raymond-Seston syndrome, which is nothing but upper dorsal Pontine syndrome. So in these individuals, the structures which are being affected is the fifth nerve, because of which there will be difficulty in muscles of mastication. There will be loss of sensory sensations over the face. And there is also damage to superior and as well as middle cerebellar peduncle. And because of damage to right? Because of the damage to the middle cerebellar peduncle, the individual will have ipsilateral ataxia and coarse intentional tremors, right? And there will be also damage to your spinothalamic tract. And because of damage to the spinothalamic tract, there will be contralateral loss of the sensory modalities within the face. And there will be also damage to your corticospinal tract, due to which there will be contralateral hemiparesis. Okay, so these are the features of your Raymond-Seston syndrome. And finally, the last important brainstem stroke syndromes will be medullary stroke syndrome. And what are the other important features of your pontine stroke? In case of pontine stroke, they will have a deep coma with quadriplegia. That is mainly in case of your locked-in syndrome. They will have pinpoint pupil, and they will have loss of reflex eye movements, right? So Doll's eye movement and oculocephalic reflex are lost. They will have decerebrate rigidity, severe hypertension, and ocular bobbing will be there, excessive sweating, and hyperpyrexia. So these will be the features of the pontine stroke. And then finally, you need to know the medullary stroke syndrome. See, this lateral medullary stroke syndrome, it is also called Wallenberg syndrome. And the vessel which is being affected is the vertebral artery, and followed by that posterior inferior cerebellar artery. Whereas medial medullary stroke syndromes, it is also called Dejerine syndrome, and the vessel which is being affected is the anterior spinal artery. And in lateral medullary syndrome, the cranial nerves which are being affected is 9th, 10th, and even 8th, and even descending spinal tract of the 5th nerve. So in case of this 9th, 10th, and nucleus of the 8th, because of which vestibular nuclei is affected, due to which the individual will have vertigo and as well as vomiting. And there will be descending spinal tract of the 5th nucleus is being affected. And that is the reason why they'll have pain, numbness, and impaired sensations over the half of the face. And not only that, because of involvement of 9th and 10th, there will be loss of gag reflex, and they will also have difficulty in swallowing. And these patients, they will also have the Hornets, right? And what will be the contralateral manifestations? The contralateral manifestations will be spinothalamic tract involvement. Then coming to the medial medullary syndrome. So in medial medullary syndrome, you have ipsilateral 12th nerve palsy and contralateral corticospinal tract involvement will be there. And that is what is your medial medullary syndrome. Okay. Then finally, the last important, okay, and you take in the treatment in case of the stroke. For example, if it is an ischemic stroke, right? For example, if it is an ischemic stroke, in case of ischemic stroke, if the patient presents to you within 4.5 hours, right? If the patient presents to you within 4.5 hours, then these are the candidate for the thrombolysis with the tissue plasminogen activator. And if it is a hemorrhagic stroke, you need to control the blood pressure of the individual. So that will be the treatment in case of stroke. Then the last important neurological emergency is there are certain neurological conditions which can present with respiratory paralysis, like myasthenia gravis, motor neuron disease, Guillain-Barré syndrome, multiple sclerosis, and congenital muscular dystrophy, that is Duchenne's muscular dystrophy. So you take this myasthenia gravis. Myasthenia gravis, it's an autoimmune disease. What is the earliest muscle that is being affected? That is levator palpebrae superioris muscle. And what will be the earliest manifestation? The earliest manifestation will be ptosis, and that too, it will be an asymmetrical ptosis. Right, that way it will be an asymmetrical ptosis. And these patients with myasthenia gravis, which is an autoimmune disorder, along with this oculomotor, along with this levator palpebrae superioris muscle, what are the other muscles which are being affected? The facial muscles, they become weak. Muscles of mastication, they become weak. Muscles of the neck, they become weak. Ultimately, there will be involvement of respiratory muscles where the individual will land up in type 2 respiratory failure, where they require mechanical ventilatory support. Okay, and these patients with myasthenia gravis, how do you treat these patients? If it is like mild myasthenia gravis, then pyridostigmine is the drug of choice. if it is mild myasthenia gravis. Whereas moderate to severe form of myasthenia gravis, you need to give steroids. And in all these patients with myasthenia gravis, you need to do thymectomy. If the age of the individual is in between 15 to 55 years, you need to do thymectomy. Right? And these patients with myasthenia gravis, they can present with respiratory paralysis. And another important neurological disorder which can present with respiratory muscle paralysis is motor neuron disease. And what is the most common form of your motor neuron disease? That is amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis, it is both upper motor neuron and as well as lower motor neuron paralysis. And these patients, in the last, there will be respiratory muscle paralysis causing type 2 respiratory failure. Right? And what is the type of motor neuron disease where you have predominant lower motor neuron involvement, spinomuscular atrophy? And what is the type of motor neuron disease where you have predominant upper motor neuron involvement, primary lateral sclerosis? And these patients with motor neuron disease, how will be the prognosis? Worst prognosis. And you don't have any specific drug. The only drug which can stop the progression, right, which can reduce the severity is riluzole, and another important drug is edavarone. Okay, then followed by that Guillain-Barré syndrome. See, Guillain-Barré syndrome, it is a demyelinating neuropathy, and it is a peripheral demyelinating disorder. It is not central, peripheral demyelinating disorder. And what is the most common form of Guillain-Barré syndrome? That is AIDP, that is acute inflammatory demyelinating polyneuropathy. Right? And in these patients with the Guillain-Barré syndrome, there will be ascending type of paralysis. Initially lower limb muscles, then trunk muscles, and then upper limb muscles. And finally, in 5% of patients, there can be respiratory muscle involvement causing respiratory muscle paralysis. But what will be the earliest manifestation in Guillain-Barré syndrome? The earliest manifestation will be absent deep tendon reflexes, and that too, the ankle jerk will be lost. But how will be the prognosis in Guillain-Barré syndrome? The prognosis overall, it is good. Right? And how will you diagnose this Guillain-Barré syndrome? The investigation of choice is the antibody, that is anti-GM1 antibody will be positive. And what will be the drug of choice in case of Guillain-Barré syndrome? Drug of choice in case of Guillain-Barré syndrome will be intravenous immunoglobulin. And there is no role of steroids in case of Guillain-Barré syndrome. And the other alternative therapy is plasmapheresis that you can do in patients with the Guillain-Barré syndrome. And finally, multiple sclerosis. It is another important disorder which is having the worst prognosis. And these patients with multiple sclerosis, it is also a demyelinating disorder where the demyelination is predominantly within the central nervous system. And in these patients with multiple sclerosis, the most common manifestations will be sensory symptoms, followed by that, the most common cranial nerve which is being affected will be the optic nerve. And because of this optic nerve involvement, the individual will have optic neuritis, they will have the visual impairment. And these patients with multiple sclerosis, in the last, there will be involvement of respiratory muscles and they can cause respiratory muscle paralysis. There can be demyelination of the optic nerve, demyelination of 9th and 10th nerve, because of which they will have difficulty in swallowing, right? And there can be demyelination of corticospinal tract, where the individual will have upper motor neuron signs. There can be demyelination of cerebellum, where the individual will have cerebellar manifestations, right? And the characteristic pupil, Argyll-Robertson pupil, is another important thing you need to know in multiple sclerosis. And they have a characteristic sign that is called Lermit sign. That is when you flex the neck, you have electric shock-like sensations down the spinal cord. Lermit sign is another very, very important finding. And what is the most common type of multiple sclerosis? That is RRMS. Relapsing remitting type of multiple sclerosis is the most common type. Comparatively, it has good prognosis. Right? And in these patients with multiple sclerosis, like whenever you do an MRI, what is that you will observe? A demyelinating lesions. And these demyelinating lesions in multiple sclerosis are mainly within the periventricular area. And that will give you a characteristic Dawson's fingers appearance within the MRI. And you need to do gadolinium enhanced MRI. Right, gadolinium enhanced MRI. And whenever you do CSF analysis, there will be presence of the oligoclonal bands. Right, there will be presence of the oligoclonal bands. Okay, and the name of the criteria for multiple sclerosis will be McDonald's criteria. And what will be the drug of choice in acute episodes of multiple sclerosis? That will be steroids. And what are the drugs which are given as a maintenance therapy? We give interferons. we have glatiramer acetate, natalizumab. So these are all the drugs which we give for the maintenance therapy in multiple sclerosis. And lastly, the type of congenital muscular dystrophy which presents with respiratory paralysis is the Duchenne's muscular dystrophy. Right? So Duchenne's muscular dystrophy, almost all the forms of congenital muscular dystrophies, they present with respiratory paralysis. But what is the most common form of congenital muscular dystrophy? That will be your Duchenne's muscular dystrophy. And what are the important features in case of Duchenne's muscular dystrophy? That is the presence of the Gower sign. Right, that is the presence of the Gower sign, and that Gower sign is mainly because of the proximal muscle weakness, quadriceps weakness. There can be development of this Gower sign where they will have difficulty in getting up. They climb on themselves to get up. That is called Gower sign. And another important feature in DMD will be there will be pseudo hypertrophy of the calf muscles. Right, pseudo hypertrophy of the calf muscles where the muscle is replaced by the fat and as well as connective tissue. Right, and in these patients with DMD, proximal muscles are more involved than compared to that of the distal muscles. They also have bony abnormalities, and that particular bony abnormalities will be in the form of progressive scoliosis. And what would be the cause of death in these individuals? That is respiratory paralysis. Okay, and what will be the cardiac involvement in Duchenne's muscular dystrophy? That will be dilated cardiomyopathy. Right, and it is a disorder which has the worst prognosis. Only thing, steroids, they may have a minimal role in these patients with the Duchenne's muscular dystrophy. So these are some of the emergencies in the neurology, right? Yes, P, right? I will send you the PDF, right? And it was not interactive because, right, I wanted to quickly brush up all the neurological emergencies in just 1 hour. So that is the reason why I was not very much interactive. Okay. So with this, I will wind up this particular session, and in the upcoming sessions, we will discuss the emergencies in the nephrology, emergencies in the connective tissue disorders, and toxicological emergencies. With this, let me wind up this particular session. Thank you very much. See you in the upcoming session.